Good morning, everyone. I'm Dr. John Anderson. I work in the Department of Internal Medicine at Georgetown Public Hospital. And I was asked to share today on COVID-19 and mental health. And it's a very important topic. And even as I prepared this presentation, I was led to review our National Mental Health and Action Plan, 2015 to 2000. And there I noted what I would call a mantra that we have embraced. And to quote that mantra verbatim, it says, "There is no health without mental health." And certainly this statement, I believe, encapsulates and really embodies the ethos of the Guyana Mental Health and Wellbeing Conference. And in fact, the World Health Organization has determined that 1 in 4 people in the world will be affected by mental or neurological disorders at some point in their lives. So statistically, what this means is that over 450 million persons around the world will be suffering from a mental illness. And to me, that's a very big number. So mental illnesses such as depression, anxiety, are more common than non-communicable diseases, which is the area that most of our clinicians actually interface with. And right here locally in Guyana, a study was done by Dr. George Valesirio and Dr. Byro Ari and others. And it found that over 200,000 Guyanese are suffering from some form of mental illness. And so what this does is that it basically tells us that 25% of the Guyanese population is affected by mental health issues. So that for every Guyanese who may not necessarily be affected by mental health issues, you more than likely know someone who is affected by a mental health problem. And certainly, as we focus into the current pandemic, we will realize that this pandemic has brought with it some public health challenges facing our communities. And as a result of that, we are seeing that struggle as it relates to mental health, because we are certainly in unprecedented times. At no other point in recent history have we had to deal with a pandemic, at least not in my lifetime have I known of a pandemic. But certainly we are facing the full force of the COVID-19 pandemic. So the public health challenges facing our communities are very, very different to what we have become accustomed to. However, as we address the physical health and epidemiological aspects of COVID-19, it is critical that we also consider the mental health impact of this pandemic. So there are serious psychological aspects to hospitalization of patients and family members who are directly affected by COVID-19. And when we examine the fact that a lot of patients who are COVID positive, once they have serious illness or severe illness, they tend to be hospitalized. And given the fact that we need to protect the persons who are not infected, there is not that visitation allowance, there is not that interaction. We do allow for video conferencing, but even that seems not adequate to alleviate fears and concerns that persons may have. And therefore, hospitalization for patients and even staff and family members pose a serious psychological problem as they think about their relative being in the hospital. There is the fear factor, there is a genuine concern, of course, and so therein lies that mental health challenge that we oftentimes see manifesting in different ways. So prolonged exposure, in some cases, patients are in hospital for weeks and months. That prolonged exposure to a constant stressful environment, invasive procedures, and the perception of threats in the intensive care unit can be expressed oftentimes as traumatic, leading to long-term psychological harm for our patients. But not only what we observe confirms or suggests that there is a mental health challenge. Evidence certainly suggests that survivors of ICU treatment are at an elevated risk for post-traumatic stress disorder, depression, sleep disturbance, poor quality of life, and cognitive dysfunction. And so this is documented evidence that supports what we see and definitely supports the idea of looking at how COVID-19 has influenced the mental health of our people. So even family members experience distress and fear and even dread, anxiety about hospitalization. I can certainly tell you that in my own experience, whenever family members are informed that the patient needs to go to the COVID hospital, there's an immediate resistance, there is dread and fear. That person oftentimes will only go if it's a matter of life and death. Of course, in some cases, persons are educated and they understand that this is for their benefit, and so they do go. But not only the patient is affected, the relatives are fearful and anxious about hospitalization for their patient. Of course, as I mentioned before, we do have to restrict visitation to prevent cross-infection and so on. And that in itself also creates that environment of concern and worry for patient's relative. So the traumatic and stressful aspects of the environment and the involvement of persons in this pandemic, it poses a risk for psychological harm, even to clinicians. Doctors face tremendous struggle as they see patients die, as they see patients move from what appears to be ready to discharge, has gotten better, and then the patient takes a turn for the worse. There is only so much a doctor can endure, or a nurse can endure, if so many patients keep dying, and you're hoping that patients would live. I actually heard some of my colleagues express this type of sentiment, that I really thought she was going to live, or I really thought he was going to live. But then suddenly I came and realized that that person had passed. And they feel it, and so that really creates that psychological stressor that even our healthcare workers, our clinicians, our nurses, and our physicians face. And even before COVID-19, when we had other global outbreaks such as SARS and MERS and Ebola, persons in the health sector experienced burnt out, compassion fatigue, lower job satisfaction, low morale, and job stress. And certainly COVID-19 is far worse in comparison in terms of the acute effect of COVID-19, affecting not just the health of persons, but a number of other spheres, economic, private life, etc., etc. And so persons are certainly having to interface with their own emotions and struggle in that regard. So the traumatic and stressful aspects of involvement in a pandemic creates its own mental health risk, both for patients and staff, as I mentioned before. So certainly it begs the question of what our health systems could do, should do, must do to be able to mitigate these effects of the COVID-19 induced mental health issues. And so health systems certainly need to anticipate mental health needs of patients and staff, family members, and prepare some supportive mechanisms to assist persons who are dealing with the COVID-19, the effects of COVID-19. And here locally, it's important for us to state that very clearly, because we are seeing not just the effects of the COVID-19 infections and what it has done to persons' psyche, but it also presents a challenge to our cultural norms, because now our health systems will have to take a second look at what can be done to offer the support to families and to prepare those resources that we can offer to persons who are affected by COVID-19. This COVID-19 outbreak will have an increasingly negative effect on mental health, as we can see the trajectory of the mental health concerns in COVID-19. And so we can see a pattern of increasingly negative effects on mental health in our communities. Now, of course, as directed by WHO and the CDC and so on, we must practice social distancing. We must stay 3 feet apart, 6 feet apart, and which is different to pre-COVID. We were hugging and we were fist bumping and we were interacting with each other in a very personal way. But now social distancing measures, while necessary to stop the spread of the virus, increases the risk for loneliness, isolation, and anxiety. And you can see, you can begin to imagine which populations would definitely be affected pretty early. The elderly who are home, and maybe before you had younger people in the home interacting with them, but now the young people who are asymptomatic in many cases could be carriers, and therefore that there must be some degree of distancing even in the home. So then that elderly person becomes more and more isolated and insulated within their own thought process, which then feeds into that mental health struggle that we are talking about here today. So while necessary social distancing there is that resultant that we are now interrogating in this conversation that we must deal with and find ways to mitigate. So there's a high potential for individuals who would have had pre-existing mental health issues to experience further symptom exacerbation, because their baseline would have been a particular mental health issue. And then when you add COVID, when you superimpose COVID onto that, certainly you can see that circumstance where there is exacerbation of their baseline mental health issues. So we can oftentimes see not just exacerbation, but impairment in their functional status due to increased stress and fear about this outbreak. And I can tell you that there is a big fear factor. There is a huge fear factor. And even if you want to consider what fear does to us biochemically, you will understand that what that is doing is creating a world within those little pockets where people are isolated and are just thinking about this thing, that people are having a different reality than some of us who understand things differently. And so we have all of these issues that are popping up that's no fault of anyone, but certainly is a definite spin-off of COVID-19 infection. And so being isolated at home increases a number of other things, including one, family and financial pressures. If you're home more, you consume more, you use more resources, and that brings an economic fallout as a result. And so that can move on to result in poor mental health within the family structure. So individuals may face unemployment. A lot of persons have been laid off because the private sector particularly couldn't sustain persons who within the context of COVID-19 restrictions, there's less economic activity, and so it became necessary to lay some people off. Some people had to be let go. And so now when you look at the individuals who would have become unemployed, housing instability, food insecurity, because the farmers in every area of farming would be affected as well. If you were able to sell a certain amount of produce pre-COVID, you're not selling that amount now in COVID. So they would have had to cut back on that. So food insecurity became part of the conversation. And so while we're doing all of that, there is the caregiving responsibility for children and other family members. So when you pile all of that responsibility on an individual, you can see how their coping mechanisms can be overcome. And that struggle that was not there pre-COVID becomes a reality in COVID. Those persons within homes who experience trauma and violence in their intimate partner and family relationships are now in close and constant contact with their abusers. So it increases the risk for abuse, continued abuse increases. And you can see the reality playing out within our society where we're seeing reports of more violent acts within families and even leading to death in some cases. Sexual abuse, because the offender is there in the home oftentimes and the victim is in the home as well. Pre-COVID, the offender might have gone out to work and then come back. The victim might have gone to school and come back, but now everybody's at home. And we're distancing for the most part. So you have persons in little isolated pockets of seclusion. But if someone has an intention, then they can easily execute that. All right. So certainly that also leads to, and then psychological trauma as well, not only physical, but the verbal abuse, the psychological trauma that's happening in some homes. So persons may be at increased risk for victimization as a result of all of these things. So at the very time that individuals affected by mental health are likely to need more support than usual, the mental health systems are at risk for losing capacity due to hospital spillover and clinic closure to promote social distancing. So as the need for mental health support increases, our systems, as a result of the measures needed to curb COVID-19, are also, if you want to use the word downsizing to accommodate the COVID-19 pandemic, but then the need increases. So therein we have a deficit where persons with those needs are not being catered for sufficiently or adequately. So mental health systems are so important. We need to build capacity so that we can cater for our citizens who are affected. So to my mind, innovative models, we have to now look for new ways to serve persons with mental health needs. So we have to find innovative models to deliver mental health and to support communities in the midst of this pandemic and to prevent a worsening mental health crisis. Some persons may argue that we're already there. So it just points to the fact that the situation has become pretty serious, and it's something that we need to act on as, in an urgent manner. So there is opportunity, nevertheless, for the health system to engage in planning, resource mobilization, and for new interventions to address mental health challenges as a result of COVID-19 outbreak. So the best way to get things done sometimes is to collaborate so we can draw on the strengths of each other. And this conference is definitely an example of that, where we're able to pull on different resources. So we can collaborate within the health system so that we can bring resources to speak to this issue. So additionally, health system must offer support mechanisms for buffering outbreak-related stress. The previous presenter spoke about stress, and I thought she had seen my presentation, but clearly she didn't. But outbreak-related stress, I recall when at certain points, at certain peaks in the outbreak, patients who would have been scheduled to return to hospital for review, reevaluation, and medication refused to come. So when they came back to hospital, they were in a worse state than when they were last seen. Blood pressures are sky high, blood sugars are elevated, legs are swollen, people are sicker now. But they said, Doc, I was afraid to come to this place. So I would often say to patients, Georgetown Hospital is not the only place where COVID exists. It's a pandemic. You can get COVID in your home. So, but the fear there, the home is a place of safety, and so we feel safe in our homes. And so persons would have made that decision to stay in-house until something blows over, until they hear, well, oh, it's not that bad out there. And so definitely our health systems need to offer that support for buffering all of the fear and the outbreak-related struggles that exist. And just jumping on, piggybacking on what the previous presenter said, I see there, even in the workplace and so on, as they spoke about, I see the need to cater for, and that is where our culture needs to now begin to adjust to accommodate the new norm. So this includes interventions for patients, for families, for example, to provide trauma-informed ICU care, providing mental health resources and education upon discharge for patients, and to support virtual visits. So right now there is that virtual, there's that call-in that exists. But of course, as we deliberately talk about the conversation, have the conversation, we can then make that a focused intervention that we expand on so that we include the family members even more. But then that, of course, will speak to staff availability, because you already have worker burnout and things like that, physician burnout, nursing burnout. And so if you're going to do that, you need more resources to do and accommodate something like that. So certainly, those are all good things, I believe. And I think they will all produce very good results if we're able to put those things in place. And for staff as well, right? Occupational mental health resources to support those persons who may be ill, who may have their own issues, mental health issues. Their families, they may have some issues with their families. They want someone to talk with, but they're working with their own issue, dealing with this pandemic. And then, of course, like I mentioned, you can have that overwhelming of your coping mechanism. So one of the things that I think is very commendable, not just because we are having this conversation, but Guyana has stepped into that domain. So we have, and I wanted to take the opportunity to comment on it because I think it's noteworthy. We can't just always say, well, you know, we need to do this. We need to say when things are done right. Also, we have to have that balance. All right. We, here in Guyana, the government has embarked on a national suicide prevention plan, 2015-2020, and also a national mental health action plan. And that's pre-COVID. So it means that they were forward thinking. And I think there's something to be said about that. They stepped in boldly into that arena, even before COVID was even a thought in anybody's mind. And I think it's noteworthy, and it's something to say kudos to. So I wanted to take the opportunity to say kudos. All right. Yes, we get some applause from the audience here. You know, kudos, you guys have done well. And this is just an extension. So this is building upon a foundation that was set before. Also, I think what is new for us, or what is now being labeled telehealth, where you're able to pick up the phone and speak with a physician or a trained mental health coach, and you might not be able to go because, of course, COVID-19 restrictions would not allow, but certainly you can pick up the phone. So telehealth, and including insurance coverage for said telehealth, because here in Guyana, if you're gonna do that, the cost, the burden of cost is on the person seeking help. So if we can get some insurance coverage for said intervention, that will be good. Persons don't have to worry about how many times they want to call their mental health coach. They can do so knowing that there is that subsidizing of the cost. All right. Extending medication supplies. I mentioned we have our clients who would not come out of fear, extending medication supply for longer periods, increasing provider mental health training, so that we can have more resource persons, virtual peer support. Again, everything is now virtual. We're here virtually, right, to make the point. So certainly virtual peer support and virtual substance use support. Those groups can help us to ensure that our community mental health needs are met. And so I think to summarize this issue, COVID is a virus that caused an infection. And in and of itself, even though there is that psychological, biological aspect of what COVID does, the real fallout is the consequences of measures that we would have had to put in place to ensure that we put a halt on the spread of COVID-19. And I did mention of the economic setbacks, the societal, socio economic setbacks, and then the family, the private in-home circumstances, which then would have been precipitated by the in-home dwelling of abuser and victim, and then persons being laid off from their jobs. Where do I get money from? Crime. And so you have all of these issues. Fear then becomes a norm. And so we can see those mental health challenges becoming a daily reality for those people who are directly affected and those of us who are indirectly affected as well by COVID-19. I talked about some solutions that we can put in place to mitigate these mental health issues, and some of them are new for us. And culturally, it's a bit of an adjustment, because all Guyanese know what is culturally the norm. What is the cultural norm here as it relates to mental health within the workplace and in wider society. So at this point in the discourse, I will pause and I will open up for questions from or comments from the online viewers and from the viewers who are right here, who are cheering so lustily. Yes, we have. You want to come?
Right. So I have two questions. You were speaking about the buffering stress. I want to know. Oh, you can't hear me. Yes, you were speaking about the buffering stress. I want to know about that, not only for the patients, but the healthcare workers. Do you feel like there is some sort of a lack of compassion with the healthcare workers when it comes to dealing with patients during this time? Because they too are stressed with the current conditions, private issues, and to relate to the patients who are also stressed, that is difficult. So how do we remedy that?
So I need to speak to the question itself. She said, do you feel that there's a lack of compassion? She's setting me up now. So should I say, oh yes, there is? And it goes on record, as Dr. Anderson said. So what I think really is that we can have an increased awareness of the needs of others. So this is an opportunity really for us to take a second look at our approach to the needs of others. Compassion might have been there, but education might have been lacking, awareness might have been lacking. And so this has created that beautiful environment for us to evaluate, reevaluate, learn and unlearn some things. So I think this is where we can capitalize on the moment. Because the environment is not right or the opportunity wasn't presented. So compassion might have been there. I feel a certain way, but then do I feel the need to express that in a particular way to you? But then now with the pandemic, it's not just me, it's not just you, but it's her and him. So everything then comes up. So I think certainly we can focus on being more compassionate and in a deliberate and a very structured way, training and education, how to express that compassion. Because of course I can express compassion in the way I know, but then you don't necessarily receive it that way. So certainly it's an opportunity, I would say.
You spoke about measures. Is there a lack of empathy in these measures? Because you know how persons, they have their own opinions as to some of the things that the measures that the government puts in place, right? And they would complain about they don't understand how I'm feeling when they do stuff like this. So is there a way that measures can be put in place, but you take more into consideration the impact it has on the mental health of the public?
Right. So the question that she asked has to do if there is a lack of empathy regarding, the struggles of others, so that when measures are put in place, those measures are specific to the need that exists. And I think sometimes it's difficult to relate, and that's a fact. Sometimes it's just difficult to relate. And so, as I mentioned in the presentation, there is that direct effect, and then there is the indirect effect. So even if I'm not directly affected, there is that I know someone who's affected. And the stats support that in terms of, in our population, a quarter of that population is affected by mental health. So in a room of any 4 people, one of them does have an issue with mental health, statistically speaking. So that empathy now can spring forth because the issue has precipitated itself and has come to the fore, so that persons now can certainly rethink, should I take this approach, even from a governmental standpoint, that's as you asked. And so again, this is an opportunity to take a second look. Is this the best policy? But that has to be a deliberate conversation. Because if I've been doing something the same way all the time, then I may not think that I need to do it differently. But like I said, this pandemic has really presented us with some golden moments. And so it's an opportunity for us to take a second look at policies, at the plans that we have. And so even from an organizational, governmental level, I'm sure that there is that process taking place. And the fact that we're having this conference speaks to that.
So we also have a second question over here. So we'll have, so you want to come over?
But there's a question in the chat.
Okay, you could address that one.
Hi, good morning.
Hi.
All right, so I am I'm a cognitive psychotherapist, and I've had the experience of working recently with someone who had contracted COVID. In fact, she lost her husband. She survived. So I more or less have been working with her from the time of becoming aware that she did contract COVID, to the point of surviving that process, and then putting her back on the road towards recovery. What I observed though is that she developed during that period some mental health challenges like hallucinations, chronic anxiety issues, and so on. So I wanted to know so when I did my research, I realized that indeed there was research out there to indicate that some persons who would have contracted COVID have developed some form of neurological, psychological challenges. I don't think enough is being said about this as a side effect. And I can say from my own personal experience that having worked with her, I was able to be successful in part in terms of working with her from that stage of being an extremist to basically one towards recovery, whereby she has returned back to her normal life. So I think we must be able, we should emphasize the challenges that COVID is a big thing, and it has severe impacts on not on just on our overall physical self, but there's a lot of psychological elements attached to it. Outside of that, from a first responder perspective, I was speaking to just listening to the question that was raised by my colleague just now. There is a situation where many doctors and emergency nurses, in the heart of everything, is likely to suffer from moral injury, which is basically a condition where you're challenged to make a decision as to whether someone was still alive or not. Under normal circumstances, that would be an easy call. But because of the magnitude of COVID-19, you have a situation now whereby first responders are thrown into an environment now. Apart from developing general anxiety issues, moral injuries coming to the fold in terms of the mental health challenges. And I think again we should have more discussion on the impact of moral injury on the overall well-being of our doctors and nurses. There's a lot that is going on, and this forum is a good platform for us to kickstart those discussions. I know there are many persons waiting to ask questions, so I'm going to bring it to a close here.
One thing I want to say to your comment. You talked about your training and your intervention with your patient. And the aspect I want to highlight is that were you not trained to respond, then you would have been at a loss in terms of how to deal with this person. And this is what I indicated earlier, that we need to seize the opportunity for education and training. You could have only responded, and you actually answered your own question. You could have only responded appropriately because of the investment that you made earlier, okay? And now your patient is on the way to recovery, and you seem to have done a pretty good job. So the training gaps, in part, have to do with, well, firstly, at the policy level, the policymakers level, because the question that this young lady asked, when she asked if there is a lack of empathy at the level of the decision makers, really what she was pointing to is that lack of awareness or knowledge. So we need to have training at the policy level, policy training. And we also need to invest in our first responders, doctors, nurses, because these are the people who are going to the community and interfacing with all the people who COVID-19 positive and those affected by the infection. So the healthcare workers, and then to the community level. At the community level, you have community leaders who serve as surrogates for many things in the community. And you need to train those people, and they can be your man on the ground to help intervene, so that you have someone there who you can liaise with, who has training. So at the community level, at the healthcare level, and at the policy makers level.
If I can add to one of the challenges in Guyana, and then, well, basically, generally speaking, it's within the Caribbean. we have a tendency focusing more on symptom management rather than recovery. So we need to, it is my personal view that there's a need to move from symptom management of cases to one geared towards implementing measures to ensure that that person goes back to it goes into recovery mode towards their original self in terms of where they came from, and and to ensure that that person has a second chance of living a successful, meaningful life, despite experiencing a period of extremism.
So I think what I'm getting there is long-term follow-up.
Correct.
Long-term follow-up, right?
Yeah.
Yeah, certainly. And I hear him, because the patient comes, we deal with the immediate, the acute issue. The patient is on their way, but then they somehow fall off. They're just lost. And because of that, they cycle back in the system, maybe worse off than before, or back where they started. So what he is saying really is, look, we need to have long-term follow-up, and this is where the training comes in, because you have to have the resources to do that.
I'll give you a good example. Someone that is basically battling with behavioral health, meaning a combination of substance abuse and mental health challenges. On average, that's a young person, right? Based on the cases, would come in with some anxiety issues. You give them Valium to get them calm. You prescribe lorazepam as a medicated drug. You address the short-term need, but because of the effects of those medications, you kind of indirectly set them up for being in that condition for a long time, because if they don't have access to that drug, the withdrawal symptoms, and you don't address that problem directly because it's too much of a headache, so you give them something else, and that person is lost for life. Now, if you make use of elements such as psychological first aid, as an early intervention, you can more or less de-escalate those concerns, and move them from based on the stress continuum that is attached to psychological first aid, move them from being in the orange or yellow zone, or borderline red zone, to the green zone, whereby they live meaningful lives, having been exposed to a mild form of a mental health challenge, but you've been able to put them back onto the path of recovery. That is where the gap exists right now. And we need to fix that.
So what you're pointing out there is not what the scenario that you highlighted is not best practice.
No.
So
it's not.
this comes back to training, so that what you describe is not best practice.
That's not.
So you later on described a different approach. There is a place for pharmacologic intervention as a first measure. There is a place for that, but it couldn't be the standard of care.
It shouldn't be the first response.
There is a place for it depending on the initial presentation,
Correct.
but it cannot be the standard of care. So training allows you to know how to use your resources, when to use your resources, and which resources to use for which patient.
Correct.
So we cycle back here now to proper, robust training. So you just describe a deficiency that is fixed by training, proper training. All right. So we're highlighting another point there. Check.
All right.
All these things. So there isn't a coupled up with the about me when I started feeling or I get cold. So I think that's another aspect.
How do you feel about persons who are trained to go into the community and reach those people where they are? How do you feel about that? Well, I'm sure in every community you can find passionate people. People impassioned for that particular cause. But before you go on, it doesn't necessarily have to be you going into the community, because you will be burnt out after a while. So you train, you diversify training, and you have those people who will go to the community and check in. How are you doing today? You know, and they know how to tease out those. So by the time the patient comes back to your office, the patient had a continuity of care by trained personnel, so that you didn't have to do everything.
So
You see?
in short, what you're saying, there's mental health and
Yes. I don't know about the word weaponized, but certainly, I don't know if I want to say weaponized, but certainly utilized. Certainly.
All right, it's a pleasure being here.
Yes, it's a pleasure having you. If I don't be careful with this crew, Interpol will be looking for me after this. So there is someone commented, this is so true. I'm not sure to what, but certainly. Oh, no, this is, any comments from persons on the call? Any questions or comments? Tell me when to go. Yeah, what time is it? Are we on time? Let's keep 9 or time.
Oh, we got 10 minutes. So I actually had a question for you too, or a comment. So it seems like your resources are pretty low right now. So my question is there a lot of burnout amongst the healthcare workers in Guyana?
I don't even have to allow you to finish this question. Certainly. Okay. So if you just have a heart-to-heart conversation with any 10 nurses or doctors, just go to the COVID hospital and you grab any 10, take them to lunch. You will be able to gather such rich data, because persons are burnt out. And you have cases where the staff have become so broken, so involved in the patient's care, that when a patient dies, that person is in tears, the healthcare worker, not the relative, because I really was hoping for this one to pull through. She was doing so well. She's so young. He is so young. And then you come to work the next day and it affects you so much. That person just couldn't contain themselves. And that speaks to the investment, the emotional, the investment that they have made, because everybody wants this pandemic to be over. And so definitely there is burnout. There is a burnout issue.
And I think that's really important. We actually are doing on burnout in October City. That's going to be presented later in the conference by Keely Chesson. So I think that would be really good for you to attend, because I think it would be a lot of feedback and interesting points to compare. But I also wanted to know, from your perspective, you did mention a lot of the changes that were required because of COVID. Do you feel like Guyana has the capacity to, invest in all of these changes that we need, like telehealth? Do you feel like there is capacity to do that within Guyana?
There certainly is capacity, but capacity building is never complete. There is always a need for more. And so there is capacity, and particularly because of the pandemic, we are now in touch with social media on a different level. as pre-COVID in comparison to pre-COVID, so that persons now are able to talk like this. Before, this was not the standard. This was not the norm. So we certainly have built up some capacity to be able to accommodate the new norm, and we can piggyback on that if you want to talk about telehealth. Yeah. And then, of course, there are other types of capacity building that has happened since over the last year and a half, thereabout, so that we now are in a place to jump off from that. But certainly we need more. Yeah. We have always been a very direct and personal society. When we wanted to talk, when we wanted in the past, we would gang up and talk. We would meet up and talk at somebody's house, at the fish shop, at wherever. So now we have had to shift to a somewhat virtual world, but there is no established arrangement for healthcare workers to have an outlet. And that is why there is none. And that is why the virtual meeting place that is specifically designated for that purpose is something that I talked about in the presentation. But apart from that, telehealth, being able to call someone who is trained and say, look, I don't know how I feel today. I don't want to go to work today. I feel whatever. But to access that service comes at a cost. And that is why insurance coverage to take care of that cost would help. You would see people picking up the phone and making those calls and having those open conversations about their struggles, okay? And not just for healthcare workers, but in general, we would, I imagine, I don't want to assume the research question is correct. But certainly we can look forward to see decline in rates of suicide and so on, where persons would want to talk so that you delay that action phase. So telehealth is one, designated virtual meeting places where we can have these peer groups and where we can talk, a kind of an Alcoholics Anonymous type of thing, where you can meet and talk and share your struggle and cry without being judged. You understand? We don't have those spaces. It's non-existent, right? The ladies would know though that Guyanese people talk a lot about, we find ways, the women more than the men, to talk about people and issues, right? But in a very Caribbean type of way. But that can bloom into something more, right? I want to use Guyanese vernacular, but I wouldn't, because we don't have, everybody here is not Guyanese. You know, we would say talk name, as in we're talking about Dr. Denton today. Oh, I don't like her, or something like that. The women would meet up and they would have these kind of conversations, right? And they're doing it too now. But out of that same cultural foundation, if I can put it that way, you can have designated meeting places where we can meet and talk, and we can have those same kind of good flowing conversations. But that has to be very deliberate. And that doesn't exist now. Where you, in your locale, where you are. So in your locale, you're the specialist. That's what it is. You're the specialist. So when you refer, you're referring upward, okay? But if you want to sort of decentralize what's happening at your locale, then maybe you need more people, more training, and more diversified programs, which will make your first responder base more diverse and larger. And so it may delay the time to refer upward. And some things may even be taken care of at that level. So certainly what you're kind of expressing is that for you to have the need to refer upward, it means that your resources have been exhausted. So limited workers, I mean, I've never seen where you work, but right, limited workers and diversified training. That's what I would say to that.
So this is a positive review of your performance. So
And
excellent job, excellent presentation.
Yes, thank you.
Yeah, and I totally agree. You did a wonderful job. This was really great to have you here.
Thank you. It's good to be here.